Hello everyone, today I will be presenting on the effect of COVID-19 in remote Aboriginal and Torres Strait Islander communities, focusing on the public health response, interventions, and the quality of available evidence. COVID-19 is a highly contagious disease caused by a virus primarily transmitted through respiratory droplets in the air. The virus is known as a severe acute respiratory syndrome, coronavirus 2, in brackets SARS/CoV/2. The disease began spreading around the end of 2019 and then became a global pandemic in 2020. COVID-19 causes short-term effects in people such as cough, sore throat, fever, and shortness of breath. The disease can also cause long-term COVID-19 symptoms that persist after a duration of 12 weeks. Long COVID symptoms include changes in mood, such as depression, anxiety, or stress, heart palpitations, chest pain, changes in body senses, like a change of smell or a change in taste, problems with memory, concentration, and joint and muscle pain. Since 2020, COVID has had a significant impact on the Australian economy. Measures such as stay-at-home orders, trading restrictions, and social distancing were put in place to reduce the spread of the virus. Beyond the direct health impacts, the pandemic has disrupted livelihoods, mental health, education, and community connections, especially in already vulnerable populations. Nationally, Australia recorded over 12 million COVID-19 cases and around 23,000 deaths by 2024. However, the burden has not been shared equally. Aboriginal and Torres Strait Islander peoples, particularly those living in remote and very remote areas, face significantly higher infection and mortality rates. This was due to factors such as overcrowded housing, limited access to testing and health services, and a higher prevalence of underlying chronic diseases like diabetes and heart disease. Among those communities, Indigenous adults aged 30 to 49 were the most impacted, experiencing higher rates of severe illness and delayed access to vaccines compared to the national average. These disparities highlight why the COVID-19 vaccination rollouts in remote Indigenous communities is a crucial public health issue, and why evaluating its effectiveness is essential for achieving health equity in Australia. Several interrelated determinants have contributed to increased vulnerability to COVID-19 in remote Aboriginal and Torres Strait Islander communities. Socioeconomic factors such as overcrowded housing, limited access to clean water, and lower income levels make it difficult to practice effective isolation and hygiene measures. Many households accommodate multiple generations, increasing the likelihood of rapid transmission once the virus enters the community. Health determinants also play a major role. Chronic diseases such as diabetes, cardiovascular conditions, and respiratory illnesses are significantly more common among Indigenous Australians, increasing the risk of severe COVID-19 outcomes. Geographic and structural barriers include long travel distances to health facilities, unreliable transport, and limited cold chain capacity. Further limit access to timely vaccination and treatment. Cultural and systemic factors, such as language differences and historical mistrust of government health initiatives, have reduced engagement with mainstream vaccination campaigns. Overall, the burden was highest among adults aged 25 to 49 years in very remote areas of the Northern Territory, Western Australia, and Queensland, groups already facing pre-existing disadvantage before the pandemic. A mix of interventions were used to protect remote Aboriginal and Torres Strait Islander communities. The most consistent finding across reports and program evaluations is that community-controlled approaches, where Aboriginal community-controlled health organizations like ASSHOS led planning, messaging, and delivery. They produced the best outcomes in uptake and trust. NACCHO and the local ACCHO coordinators have coordinated outreach, culturally adapted messaging, and local clinics to reach people who would otherwise be missed. Mobile outreach clinics and the aeromedical/road teams, which includes programs led by the Royal Flying Doctor Service, were essential to very remote communities, enabling on-site vaccination and reducing travel barriers. Programs and reports show that these services improved coverage in the hardest to reach locations. Point of care testing and rapid diagnosis, which in brackets is molecular POC, help detect and manage outbreaks quickly, which in turn permitted targeted vaccination drives and reduced transmission. Recent national POC initiatives show promise for timely response. On the demand side, Indigenous-led education, narrative-based health promotion, and yarning approaches have been shown to reduce vaccine hesitancy and build confidence. These approaches emphasize trust, local storytellers, and culturally relevant materials rather than the top-down messages. Systemic snapshots and recent studies support these approaches. Overall, the evidence on COVID-19 interventions in remote Indigenous communities is promising, but constrained by data limitations, selection bias, and confounding factors. Strengthening surveillance systems, independent evaluations, and long-term follow-up is essential for more robust evidence. To conclude, COVID-19 has revealed deep and persistent inequalities in Australia's public health system. COVID-19 disproportionately affects Aboriginal and Torres Strait Islander peoples in remote areas. Lower vaccination rates and structural barriers increased infection, hospitalization, and death risk. Remote Aboriginal and Torres Strait Islander communities were among the most affected due to lower vaccination coverage, overcrowded housing, and long-standing barriers to healthcare access. If inequalities and inequities persist, future outbreaks may cause preventable illness, deaths, and loss of community trust. Ongoing disparities reflect broader health inequity and social justice. What's working now is that community-led vaccination programs by NACCHO and the Aboriginal Medical Services. Also, mobile outreach clinics and local health workers are improving trust and access. So by continuing to center Indigenous voices in decision-making, we can move forward towards genuine health equity and resilience for all Australians. To retrieve evidence for this topic, structured approach was utilized. The structured approach combined both academic and grey literature sources. I began by searching PubMed and Google Scholar using keywords such as COVID-19 vaccination, Indigenous, remote communities, and Australia. Also, Boolean operators were utilized to connect key terms, which for example were COVID-19 vaccine and Indigenous and remote. Filters were applied to include studies published between 2020 and 2024. And filters were also applied to include studies written in English. This ensured that the evidence was current and relevant to the Australian context. In addition to the peer-reviewed research, I reviewed government sources such as Australian Institute of Health and Welfare and the Department of Health and Aged Care for vaccination coverage by Indigenous status. I also drew from community-controlled health organizations such as NACCHO and AMSANT, which provided me with valuable reports on culturally safe and locally led vaccine interventions that are often underrepresented represented in academic databases. This multi-source approach allowed a comprehensive understanding of both the quantitative and qualitative aspects of the COVID-19 vaccination rollout in remote indigenous communities. These were all the references that were utilized. Thank you so much.